You're on mute.
Right, I think everybody can hear me now. So, welcome to the CPD lecture of this week. I have the honor of introducing our speaker for tonight. Very warm welcome to you, Prof. Hendriksz. So I will just then go through the short bio for the introductory thing. So, Prof. Hendriksz is a clinician scientist and global rare disease expert with more than 20 years of experience advancing the diagnosis, management, and therapeutic development of inherited metabolic disorders. So he currently serves as the Chief Medical Officer at Decentra Health and the Chief Community Impact Officer in his pro bono capacity at a rare cause. Dr. Hendriksz has led major international clinical trials, chaired global drug and safety monitoring committees, and contributed to more than 250 peer-reviewed journal publications, shaping clinical guidelines for lysosomal disorders and other ultra-rare conditions. He also chairs multiple international rare disease registries supporting real-world evidence generation. Deeply committed to global health equity, he has established diagnostic capacity, biobanking infrastructure, and clinician training programs across low and middle income countries. He holds long-standing academic appointments as extraordinary professor at the University of Pretoria and Northwest University, South Africa, and continues to be involved in medical education and healthcare systems development. His work bridges scientific innovation with real-world patient care, with a career devoted to expanding access to high-quality rare disease services worldwide. So, without any further ado, Prof. Hendriksz, welcome tonight, and I'm going to give over to you.
Good evening. I hope everybody can hear me while I just quickly get all this setup done for you. It's the usual switch over just to get everything into presentation mode. And I think you should all see me now and hear me. Please shout out if that is not, or put it in the chat, but I think you should be able to. And I'm talking to you from what's supposed to be spring in England, but it's incredibly cold. So please bear with us as we go through the presentation and things tonight. But it's always a pleasure. And I know some of the people has heard this lecture before, but I have updated it with a few more. You will see I've put in there a few new insights in there. But the crux of it stays normal because I think there's some really important lessons which we can all learn. As always, I think the most important thing is just to make sure everybody's aware of my disclosures. As has been said, I am the Chief Medical Officer for Decentra Health, which is a commercial company working with AI and registries. A Rare Cause is our project, which runs out of Fimca Medical, and that is a charitable organization. I usually express my own opinions and experience. And as you will know that things are changing in the imaging world. So images I project, I usually ask people, please do not reuse them without explicit permissions, because either I've got permissions to use them, or I have generated them from AI, or I have permission from individual patients to use them. So with all of those in line, let's start off. So when you start looking at eye diseases as a entry point into inborn errors of metabolism, the main important thing there is really just to make sure that you look at the eye in different areas and to remember the eye's different components, because actually looking at which anatomical areas involved may give you some clues as actually what group of disorders to look for. For those of you which are new to rare disease, what we tend to say, and I'm focused on inborn errors of metabolism, there are about 7,000 rare diseases, of which 1,200 are inborn errors of metabolism. So they're a smaller number, they're a subgroup, and they usually affect the eye in different ways. But looking at the distinct layers or the place they are will give you some insights of actually where to start looking. And I'll take you through. My other conflict I need to say is that I'm not an ophthalmologist or an eye specialist. I'm just a general metabolic specialist. I've seen many of these and I've worked with some of the best people in the world, which has taught me. But please speak to the real experts if you need additional advice. I'm just sharing what I've learned through all the many years. So let's start looking into a few examples. So let's start looking at corneal abnormalities first. Kind of work a little bit from the front to the back, but not entirely. So let me get my pointer going for you just here. So here you will see in the corner is an eye, which you really need to look at when you say, is there clouding present? So this is one of my MPS 4 patients, which is Morquio syndrome. And what happens here is they've got very limited clouding present. And it is really because the clouding is not a prominent feature of disorder. And really, sometimes you need to be sitting. I tend to sit on my knees in front of most pediatric patients I examine, because when you look slightly upward, you find a lot of the features are more easily seen. The other thing as well is that on the next patient, you will see a patient with MPS 1. So same group of disorders, but you've got very clear corneal clouding. You can see the thick clouding. So the cornea is stacked full of glycosaminoglycans, and this leads to progressive visual loss. And if there's any interest, excuse me, we can talk later about what you can do about it. The other thing that I want to show you is when we go a little bit lower down, this is a cornea, which is something which we call cornea verticillata. Now, those of you in Africa will tell me, but we see that commonly. It's commonly described in patients which are on quinine. It's seen on some patients with some of the TB drugs. It's also seen with a commonly used antiarrhythmic called amiodarone. So it's not unique to Fabry disease, but it's one of the features. And I always say to people, remember that common things are common, but once you've excluded the common things, think about the rare, because they may be there. So you can see it's this fine reticular pattern inside the cornea. And this is seen with a split lamp. You don't see this with a normal eye. So just important to know that. Then we see, and I'll show you some images next, of ulcerations, which we see in tyrosinemia type 2. So this is a amino acid disorder where you've got an accumulation of tyrosine. And then it causes very painful corneal ulcers. But it's really important to remember that there are many causes for corneal ulcers. But what's unique about tyrosinemia type 2, and that's one of the lessons for many of the things I'll tell you today, is look at the whole patient. Because these patients, when they get severe eye disease, will also have severe changes of their hand palms and the feet, because the tyrosine will accumulate there, crack the hands and feet. So again, if you ask the right questions, you may be able to find it. And then lastly, with alkaptonuria, which is another disorder of amino acids, of course, as the name says, it was also the first inborn error of metabolism ever described, because people saw that if you let urine stand out, it becomes black. So again, it becomes a question you could potentially ask patients, have they seen their urine turn back? But let's have a look at the eyes, because that is the focus of tonight. Let me just see, there we go. So here you see the tyrosinemia type 2 ulceration. And you will see it's not particularly different to what an infective ulceration would look like, but it does help asking the right questions. So it is important. And for comparison, I've put to you at the bottom, looking very different because this is a fungal infection of the eye, which is much more common in your part of the world. But to remember, sometimes they can be indistinguishable. So it's worthwhile asking the right questions. And of course, with a fungal infection, you would have either systemic features or purely topical features only. The next one is here, which we've talked about. It's the alkaptonuria. Now, this is a fascinating condition because the other thing it does, it causes something which is called ochronosis. That means it discolors the ears and cartilage to become blue. So you can actually see the blue tint in people's ears. But what you see in the eye is actually you see this accumulation. You see the little black dots there which are accumulating, and it's different layers of the eye that is affected. But you can see it from the conjunctiva. You can see little black dots in there as well, and some of them in the cornea as well. So that's why I say, although we say in different layers, some disorders go through multiple layers, and it's important to remember that. But these are the kind of classical black spots that you would see in a patient with alkaptonuria. Let's move on. Now, here is a sign, and I've said corneal signs, but actually the ophthalmologist will tell you we're not looking at a cornea here. What we're seeing is this little yellow blob. And I'm sure some of you will know about these. These are very common in many parts of the population. They're called pterygiums, but actually they do occur quite commonly in patients with Gaucher disease. And what makes them different is they tend to present into both eyes, firstly, but you will have other signs of this disease, which is important. So although that may be a clue, if you start asking about do they have any other problems, you will actually find that, yes, Gaucher's got many other skeletal features, big livers, big spleen. So it's a multi-system disease like many others. And it does mean there are different ways of doing it. So it is important that clinicians must distinguish between the different signs. And like I say, there are many other causes, but it's also important to keep on thinking about genetic impacts because many of our conditions are what we call autosomal recessive. And these conditions means they run in families and they will recur. So these are really important. Excuse me. Let me just quickly, I see somebody's trying to put a message in for us on the chat. Yeah, somebody said, yeah, it's pingueculum pterygium, different ways for this, but yes, it's a pingueculum, and fantastic for putting that into the chat. Please feel free to put things in the chat as you spot them, because it helps us all to learn, and there is lots of semantics involved in these things. So well done for spotting that one, and I'll try and keep an eye on the chat all the time as well. So let's go to the next one. Let's look at a few of the lens abnormalities. So here we go. At the top, you will see a patient who's got bilateral congenital cataracts. This is a patient with Lowe syndrome, but they've also got the other features. They've got renal impairment, developmental delay. So again, multi-system disease, but you could see them there. And then these ones are very classical, which are called droplet or oil drop cataracts, which you see in patients with galactosemia. Now, there's a fascinating thing here. I have seen this in patients which has not been diagnosed early. So those which has gone beyond about 6 to 8 weeks, they accumulate and you don't see them. I've also seen them in patients with galactokinase deficiency, where it's a condition where only the eyes are affected. Now, some of you may have been following the series and know that we've got quite a unique population of African galactosemic patients, which is kind of variant, which is different to the very severe classical form. And I've not seen them in an African patient. I've seen them in many of the Caucasian patients, which are late diagnosed, but not. So if anybody's seen them, please update me, put it in the chat that I know if you've seen them in the, especially indigenous Black populations. If you know, especially ones with the typical African mutation for galactosemia, because I've not seen that in that population, and it's really important to keep that in mind. The other one that is fairly common is a condition which is another lysosomal storage condition. It's called cystinosis. I'll show you some pictures now. but it's a condition which has got such a lot of other classical features. So although the eye features are important, you have to remember that with cystinosis, these patients usually have failure to thrive. They usually have significant renal impairment. They develop diabetes later on in life as well. So they've got a lot of abnormalities, and then they've got classical eye features. So I will show you those. And then, of course, we have lens changes as well in Fabry disease. Fabry disease is one of those disorders that affects all layers of the eye, but all of them are subtle, which is most probably why we don't see that many Fabry patients. And for context, when you look at the African population living abroad, we find quite a high incidence of Fabry, but we find very little in Africa itself. So you could make the deduction that they've all moved to other parts of the world, or we're just not diagnosing them. And I think sadly it's the latter. I think there are multiple patients sitting, especially my guest is in cardiac clinics. And because they've got a cardiomyopathy and they're on amiodarone, people are seeing the cornea verticillata, but actually says, oh, this is part of amiodarone, and don't test any further. And then there's also the classical homocystinuria, but we'll come to that one next. So here are some more abnormalities. Now, for those of you which are really smart, and we'll see it quickly, you can see there's another blue ring. So this is another one. So this is a Kaiser-Fleischer ring. Let's see, somebody put it in there. Oh, somebody's already got a cystinosis patient, which is brilliant. So that's the blue ring Kaiser-Fleischer, which is a copper disorder. So Wilson's disease, which you see. So again, this is an eye feature of that, but although people tend to have neurological abnormalities or liver disease, which really goes together with those. So it is important to keep looking at it. Here is the classical picture of a homocystinuria patient with a downwards dislocation of the lens. Now, homocystinuria patients also get abnormalities of the retina, but it is important that this downward dislocation of the lens, I am told it is only seen in homocystinuria. I suspect that statement is not true, because my logic tells me the reason why they get downwards dislocation is the ciliary muscle and the tendae gets broken down by the accumulation of homocysteine. And it's the ones which is pulling the lens downward that stays intact, the top ones that fray first. So I think other conditions which affects connective tissue will cause the same. And I think that may be important to put in our differential diagnosis. Most of these things you need a slit lamp, so do ask your ophthalmology colleagues to help you. And then, of course, here is another classical picture. And I'm not sure if anybody's seen that one as well, but it's so classical. Once I say the name, you will know. This is what's called a sunflower cataract. And what is this? This is just another one of the features of Fabry disease. So you'll see we've got multiple features of Fabry disease presenting in the eye. So I'm still concerned, why are we not seeing these patients? But in any case, maybe those of you who are in ophthalmology practice will start helping us to find them so that we do know how to manage them. Why do we want to find them? Firstly, there is disease-modifying treatments. There is multiple enzyme replacement therapies. There is chaperones. There's a gene therapy clinical trial in place. So there are multiple options for treatment of Fabry disease, like many of our other disorders. And that's the main reason why we say people should be looking for them. A condition like homocystinuria is quite complex when you put them all together, but isolated homocystinuria, you've got a form which is responsive to pyridoxine, vitamin B6, and you've got a form which is not. And it's a really important one because the pyridoxine ones tend to not have that severe lens dislocations. They tend to have more retinal changes, but it is important to see occasionally you find them. And they don't have the marfanoid features generally. So it's the non-responsive ones, which has got the marfanoid features, tall, lanky, and all the other problems, whereas the ones which are more pyridoxine responsive tend to present usually with stroke postpartum as commonly. Let's see who is commenting for me in the text. Yes, somebody else has added for us. Other conditions, Marfan, Ehlers-Danlos causing dislocation in specific or different directions of dislocation. Exactly. Thank you for that comment. And my logic told me exactly what you were saying. Other things which influence that ciliary and that both the tendon and the muscle is likely to cause that as well. So it is. So it's really good to see the interaction and great for me to learn from you guys as well. Yeah. Next, we've spoken about this one. And this is really the classical features that you see of cystinosis. You could see the slit lump. You can actually see the cystine crystals, which is in there. And then you can also see there the accumulation. So there you can see, and there's also some accumulation on here. These patients has got different ways of treatment. So for the systemic disease, we've got some treatments, especially to try and maintain the renal function. But for the ocular disease, there are specific eye drops which are used to help to limit the crystals accumulating in the cornea. The reason for that is, as the people who know more will tell you, that when you've got crystals and things accumulating in the cornea, it starts distorting light and it impairs your vision. So it is an important part of visual loss, and it is important to see if we could pick these patients up and manage to find them and treat them appropriately. Good. Let's go a little bit to the retina. So here are some retinal changes. So the top one here is a change which you see in the retina of patients who's got MELAS. Now the picture is seen in many conditions, unfortunately. But patients with MELAS is one of the mitochondrial inherited conditions, which means this runs from the maternal line. So it's one of the things. The name MELAS stands for myoclonic epilepsy, which you will know, and then also elevated lactate and stroke. So these are the patients who actually have these things. So a simple lactate is sometimes helpful, although lactate is quite a variable test to do, because if you use a tourniquet, it will frequently be abnormal. And one of the things which I say to people is, if you've been doing, because there's many of the other amino acid disorders which looks like this, if you can look at the serum alanine, they are usually elevated in all of the mitochondrial disorders as well. And when you've got an elevated serum alanine, you also grow more body hair. So actually these people are more hairy. So just some subtle signs which may be particularly there, but it is important to keep an eye out for that as well. So on the other side, just below it here, you've got what we call the classical, some people call it salt and pepper, because you've got black and white spots in there. And that's the Refsum's disease. And it's a peroxisomal disorder. And it's the adult variant of that. Let me see, someone is helping me. Yep. MELAS, mitochondrial encephalopathy. It's got myoclonic epilepsy as well. But yes, you're right. The name is it's fairly classical in the condition. And importantly, Refsum, so this is adult Refsum's disease, which we tend to see where you see the eye changes as well. This is accumulation of phthalic acid, which is it, and it's usually associated with a neuropathy as well. So they get progressive neuropathy, and they also get sensory loss and some of the other features. So they may look like a diabetic neuropathy in some sense, but they've got these eye changes. But again, they're not classical just for that condition. They're just part of what we see. And what I'm trying to get you today is just to continue to look and see, what do you see and what are the specific features that will make you just think about these conditions and keep them in mind. Gyrate atrophy, we'll show you some more pictures now. That is a disorder of ornithine metabolism, which has got a very classical picture as well. What's classical about patients with gyrate atrophy or hyperornithinemia is we see this in children classically around the ages of about 8 to 10, where they traditionally report with night blindness. It's a strange story, but I've got quite a few patients which was diagnosed because they've gone to a movie theater and then the children can't get out of the movie theater because in the darkness they can't orientate, and that's how they present. So that is just something. So they get night blindness then, and then they start losing peripheral vision. And basically what happens as the retinopathy progresses, the vision comes in and in and in. Now, this is a condition which is treated with an ornithine restricted diet, which is a really tough diet. I can tell you that. It's a really tough diet. And a lot of patients are not particularly good at doing it, which is why ultimately the majority of these patients turn out to become blind in their late 30s or early 40s. There is a founder mutation in Finland, and where patients are diagnosed at birth and put on a special diet, the visual outcomes are much, much better, because teaching somebody to stay on a special diet from birth is much, much easier than to tell a 10 or a 12-year-old to come on a diet which is very restrictive. So that is just so, and I'll show you the images next. So there we go. So here is gyrate atrophy. You get this really abnormal picture which looks just like it's been eaten out, and it's a really classical picture. And the ophthalmologist will tell you this is a fairly classical picture. But again, I'm fairly sure there are other things that looks like this. And specifically in the African subcontinent, there are a lot of eye disease which is unreported. And I think it's really important that we start filling up all these gaps in our knowledge bases. And as I've said again, there are two variants. The one variant is vitamin B12 responsive, similar to homocystinuria. You find it in hyperornithemia as well. Really important to try and see if you can pick those ones out, because it is really important to see that. It's a really good find if you find them easy and they are responsive. But like in most of the responsive disorders, we tend to find the minority is responsive. Let me see, somebody's helping me. So I'll get to the questions later. Let's put them in the chat. I'll pick them up later, but definitely we'll talk with them. So it is important to look at all of them. The other things as well is, here is a picture, a really lovely picture somebody's taken, and this is Fabry disease. But until I tell you, it's not obvious, but you could see it here. It's what's called train tracking. What happens is, because of the accumulation of the GL3 in the vessel starts kinking, and you see this tortuous way that they are. You see all of the vessels seems like they are kind of kinky. So that is what we see in Fabry disease. Again, it's just one of the other signs which has been reported in patients with Fabry disease. And they are usually signs of quite progressive disease if you find them. Other things is, like I said, the mitochondrial disease. There is a few treatments out, but in the majority it's not. And it is important to look at the supportive therapies, and especially for MELAS. There's now fairly good evidence that arginine can actually improve the outcomes of the strokes which patients have. So if you've diagnosed the patient, you're aware of them, when they present with the acute stroke, their management can be optimized. There we go. So here is the classical cherry red spot that people talk about. This is classical in the lysosomal storage disorders. Tay-Sachs and Grubber mucolipidosis are the really classical ones. Really important. I must say that when I start looking with them with a naked eye in the ophthalmoscope and an eye that is not dilated, I tend to see the white around it first. And then when I start focusing in, I see the cherry red spot. That's just my own personal experience. It may not be universal, but that's my experience. So I do find that an easier way just to spot that. And then on this side, I want to talk about something which is incredibly important. Now, you would not be surprised to say that you see an optic nerve, it looks pale, and the first thing that you would think is this is a patient with raised intracranial pressure. But I then paint the picture for you, but this patient is sitting in my clinic. He is playing, but he's got severe mental disability and he's got skeletal dysplasia. So although patients with MPS II Hunter syndrome can get increased intracranial pressure, this is actually infiltration of the optic nerve by the glycosaminoglycans. So do remember, this is a picture that looks like papal edema, but it's not. And it's classical for MPS II. We've not seen it in the other MPS disorders, but it may be there as well. It's just we haven't seen it. So it's something just to keep in mind. So, and we've had a few occasions where people wanted to go ahead and put a shunt in these children, and then we stopped them. And the reason for that is that these children are incredible high risk for anesthesia. So you don't want to be doing anything which is unnecessary on them. So it's a really important feature to be on the lookout. Patients with MPS II. Next, we are getting closer and closer to other parts of the eye. Next, we're going to talk about eye movements. Good. So, of course, everybody knows that eye movements is just the disruption of the central nervous system, and there are different ways of doing it. Now, the pictures here, if you go on the eye wiki, is really just to show you that there are different ways that you have abnormalities of the eye. So I'm going to take you through some of them. So firstly, when you've got horizontal gaze palsy, in our field, we see that in Gaucher disease, which means the patient has got inability to look up and down, but they can't look to the sides. So it's horizontal gaze palsy. Patients who's got supranuclear or gaze palsy upwards tend to be in our field, Niemann-Pick, but of course it's also PSP, and there's a long list of patients with eye movement disorders. So I'm not saying for one moment it's the only ones, but I do want you just to remember that for our conditions, Gaucher disease is horizontal gaze palsy, and Niemann-Pick is upwards vertical gaze palsy. What do I do in children? Getting children to do pursuit is relatively easy. And what you'll find is when you take these patients and you do pursuits, you take a pen or something, follow it. The palsies are not there, because what you will see is they constantly blink. And as soon as they blink, they can move the eye in that direction. So do look for the blinking, which means you really need to look at eye movements without them following or pursuit. And my trick is, I always say to children when I examine them, I just say to them, keep my eye close on them. And then I say to them, don't look at the top. And in my clinic, when I used to practice, we had some images on the top, and it gives me a way to look at the upwards gaze quickly. And I had some places on the walls, and I would say, don't look in the right corner. And again, because this is not pursuit, this is on instruction. So it's trying to tell them, but there's other ways of doing it as well. You can use fingers and say, look left, look right. My experience is children tend to not do that. So you struggle with it, but there are ways of getting it done. Next, below this is a patient which really caught me out as well the first time I looked at these images. So this is a patient which you can see, which has got quite significant ptosis. And then what happens is he had ptosis surgery and it improved. And what happened, it started going down again. And my first thought is, I can see this as muscle. And I thought this is really a mitochondrial disease, which is why the people would have posted it. But actually, it's Pompe. It's another lysosomal storage disorder. And this is what we call late onset Pompe disease. Pompe disease has got two different modalities. It's got an early onset. These patients with early onset always have a cardiomyopathy. They're sick, they're very early sick, and they present before the ages of 2. And then you've got always, like all of rare disease, a kind of intermediate group, which we call infantile, and then you've got late onset. I don't like that classification. I tend to speak about patients with cardiomyopathy and with Pompe disease. And the reason why I do that is that the features can be quite subtle. And this is a patient actually who's got classical ptosis from Pompe disease, a late onset patient. And of course, the diagnosis was not made there. The diagnosis was actually made quite later on in life. Although the surgery was performed, the recurrence of the ptosis was the link for people to look further and then make the diagnosis. So that's just one of the things. The other thing is external ophthalmoplegia. So this is progressive weakness of the extraocular muscles with ptosis. And I'll show you pictures of that next. It's just important to keep an eye out on those as well. And then we'll talk a little bit about oculogyric crises as well. So these are just some eye movement disorders. So here is Kearns-Sayre, which is a mitochondrial disease. And this is just the progressive picture you see from 1998, where there's very little. You could see there's a little bit of ptosis starting, and you can see as time progresses, it gets worse and worse and worse. And one of the reasons we see both the eyelids, but particularly the eye movements affected with the mitochondrial disorders, is that your eye muscles has got some of the highest contents of mitochondria in the whole body. So they are the first ones to actually fail when you've got a mitochondrial disease. And that's why people are always focusing on the mitochondrial disorders. But as I've already said, you also get retinal changes and other things. And just to perspective here as well, I've spoken about MELAS, which is a mitochondrial inherited, but mitochondrial disease can be inherited in each and every way. The commonest mitochondrial disorders are actually nuclear encoded, which means both parents carry it. So don't make the mistake to think that all mitochondrial disease is maternally inherited. That is only for specific syndromes like MELAS, MERF, and a few others, which are out there. So that's important to just keep that in mind. So those are the ones. So this is just to show you progressive, and it's just a progressive. But if you could look at them, it's both the eyelids and the eye movements. If you actually get to examine him, you see the eye movements are kind of slow and become more and more jerky as time goes on. Oculogyric crises. The reason why I want to call it is because it is very common. We tend to see it mostly with drugs. It's the sustained involuntary movement, upwards, downwards, or a certain position, and it actually gets fixed. It can last up to hours. Sometimes people think this is psychological or anxiety. You can also find some other features. People sometimes get neck extension and arching together with it. And these are all different symptoms which can be caused by the same mechanism, because it's actually that neurotransmitter pathway that is impaired, which is why you can also get sweating, tachycardia, blood pressure changes and things. And in my early days in medicine, I tended to see this quite a lot with metoclopramide, not picking on the drug, but it was just commonly overdosed, especially people develop severe vomiting, and then they think they vomited the dosage out and they continue to take more and more doses. So that is just oculogyric crises, but they do occur in some of our rare metabolic disorders, and that's really important because it's in the same pathway. And the condition which is the most prominent at the moment, and before I know everybody's staring at this guy, so he's got his oculogyric crisis fixed downwards, is that there is now a gene therapy for the condition called AADC, aromatic amino acid decarboxylase deficiency, AADC. So this is a condition which prevents with oculogyric crises and progressive brain disease. But there is a gene therapy and the early results are very encouraging. So we really encourage people to look out for patients with oculogyric crises in children primarily. In adults, it's more reasons for drug-induced, but it is possible in children. So keep an eye out for those as well. So when you look at the IEM ocular manifestations, you just put them in a quick matrix. As I've already said, your Fabry kind of tends to affect everything. Gaucher disease is usually mostly the cornea with some spleen and bone involvement. The MPS and mucolipidosis is usually cornea and retinal changes. Zellweger, which is peroxisomal, that's also Refsum's disease. They tend to be lens and retina affected. And then, of course, Tay-Sachs Krabbe tend to be retina with a classical cherry red spot. And I suspect we only see the retinal changes because the disease is so severe, so we don't see them in later life. which is potentially partially true and why we see more of them. So as we go on, so what are the red flags in inherited metabolic disease looking at the eye? So firstly, they tend to be bilateral eye disease, and I call it two eyes plus. You usually don't find only eye disease. There's usually something else. So when you've got bilateral early onset cataracts plus, or bilateral corneal abnormalities plus, bilateral lens dislocation plus, retinal degeneration, deposit in the sclera the conjunctiva, optic pathway abnormalities, eye movements plus, early visual impairment plus, and then of course there's also the syndromic clues. So hopefully I'm just give you some clues that when you see a patient with abnormal eye features, always try and ask or look for the plus, because that's the thing that makes our conditions different, because they tend to be systemic diseases, but that's true for many other diseases as well. So just keep that in mind. So what are the tools? And there are many, which I will just quickly run through it. So some of the tools that we use, slit lamps, and then all the other tools that we all see with the opticians and the ophthalmologists to look at things. OCT, optical coherence tomography, which is becoming incredibly valuable in many of our diseases because we're starting to see fairly classical pictures. And of course, this is the AI tool that actually reads it. So for those who doesn't have, and what's starting to happen is you've got AI tools, which now starts reading the opticians' OCTs to make sure they don't miss rare disease. And there's a few projects running with those, which is really important just for people to remember. The other things, when you look at eyes, just remember mydriatics, things that open up the pupils, helps you to see things better. But do remember that most of the mydriatics are relatively long-acting, so people can't drive and things, so make sure you don't put them in somebody's eyes and tell them to drive home. Pachymeters are things that measures the thickness of the corneas. We use them in the lysosomal storage disorders like MPS disorders to measure the thickness of the cornea, and that also helps us when planning for corneal transplantation. Goniometers has most probably gone mostly out of favor. Those are the old-fashioned things we used to use to measure eye pressure. Most of them are now done by the little puffs of air, the kind of air-generated pressures, which most people will be aware of. So it is worthwhile, and just to think that the eye is just a window into the brain and to somebody's life. So my final thought to you is, don't just treat the eye, diagnose your patient, and with a careful examination of ocular architecture, it provides you a non-invasive, high-fidelity window into very complex metabolic and systemic disease. And in my centers that I ran in the UK, the ophthalmologist was absolutely critical and vital in my team. We had joint clinics and everything, because we need to learn from each other. And as you know, there is the saying, find the zebra, and I say, find the rare cause. So thank you for listening, and let's see if I can answer some of your questions, and I will stop the share window.
Yes, thank you very much, Prof, for the insightful presentation. For myself, I'm more involved with the diagnostic side, the analytical end of things, so it's really nice to see the clinical presentation and the features as well that goes along with the disease. So I don't see any questions in the Q&A, but in the chat there were a couple. So I think I'll just from the top perhaps. I think, Prof, you addressed some of them already. Let's just see. Okay, there's one. I thought MELAS was MELAS syndrome, mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, not myoclonic epilepsy.
It's semantics. It's part of the thing. But yes, if you use the HPO term, that person is correct. The traditional name is to cause mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. I put the clinical features in to remind me what should I be looking for in patients. And it's the same in MRF, where it is there, it's myoclonic epilepsy is the first, but it has an encephalopathy as well. So just remember the terms overlap, and it's really important that when we start talking about disease, we do make sure we use the same terms about the same conditions.
Okay, the next one I see here, does early diagnosis and intervention reduce the eye signs in general in IEM, or would it be there by default?
That is age dependent. So, and when you look at, so first thing is, does enzyme replacement therapy influence corneal clouding in MPS patients? No, because like you've got a blood-brain barrier, you also have a retinal barrier. So the enzyme which is infused systemically does not get into the eye to change it. Now, there is a fascinating feature in that patients with CLN2 Batten's disease has got a retinopathy. And people have actually done a clinical trial to show that if you inject the enzyme directly into the retina, it will slow down the progression of the disease and the blindness. So we are starting to see more and more absolutely more classical ways of treating eye disease directly, either into the retina or into the cornea. We're starting to see that. So on that question, it's usually progressive and some therapies change it. So if you look at something like gyrate atrophy, if you can get patients to run their ornithine levels, now you can most probably help me. In my head, ornithine levels tend to usually run around 80, between 80 and 120. That's the kind of normal value I've got in my head. It may be incorrect. It may even be lower depending on the methodology. But what we say for patients is you need to run below 200 to protect your vision. Most patients struggle to run at less than 400. And when you've got 400, what you find is your eye disease is slowed, but actually it does progress. It's just you get it at a later age. But the finished population can get them below 200, and they do have protection of their vision. Some people will say, but it's a founder mutation and it's just a feature of that mutation. I can't think about any parent that's going to take their child off a diet to see if the control is true. So I think we need to accept that, yes, that is it.
Okay, there's two other comments, just excellent presentation, which we all agree on, Prof. Chris, and then thank you very much for the informative talk. There's the one last question I see in the chat. Can these features be missed during childhood and only be discovered in adults? If so, is workup for IEMs necessary or would it assist?
Oh, absolutely. We frequently see. So what we tend to find is, so you have windows where certain things occur, and if you miss that window, you miss it. And then it comes with a different window at another time. So yes, they can reoccur. Now, different things, and I haven't spoken a lot about testing because it's all about awareness, and I want people to speak to the labs. But we do have a program running in Africa, which we call the Africa Roadmap. A lot of people are aware of it. It's 16 different countries which is involved. And we've got free testing for 6 lysosomal storage disorders on a filter paper card. And those are the ones that'll pick up, but that will only pick up the MPS disorders, Fabry, Pompe, Krabbe, what have I missed now? Niemann-Pick or ASMD, the new name it's got now. And I'm still missing one condition on that list. I never remember all 6 in one go. But in any case, so they're all on there. But I always say, speak to your lab. When you start looking at conditions which are amino acid disorders, you can measure them on plasma amino acids. Now, there's a difference between plasma and serum. I don't want to get into the technicalities. It's about how to preserve samples and things. My view, again, is speak to your lab. And I know there are quite a few labs now doing some amino acids on filter paper as well. So I think the technology is evolving. I didn't touch on any of the fatty acid oxidation defects tonight, but they also have retinal changes. They also have blindness. And those we tend to find, and we use what's called acyl carnitines. Again, these are done on filter papers. But I think what I will ask, rather than me going through all of these things, I will ask you a favor that you just put your website, because you've got a really lovely website where people can pick the different tests. They can see there's profiles to check and everything. And that's why I didn't specifically, because if you know to look, you can go into the website, you can start looking, you can fill in the details. But also, like I've said, my ophthalmologist is indispensable. So is my laboratory. So do speak to your laboratory. Speak to the people and speak to the other people in the field that they could really, really support you, because don't struggle along alone. And AI tools are not perfect, but they're better than nothing. So, but be careful and get somebody to check things with you, but they can definitely be of great information. So, and if you do find additional causes that I've missed, especially Africa specific causes. I didn't talk about trachoma and things like that. Again, uh, there's not a lot of literature, pictures, and images in the European scientific literature. And I think we need to start building it up and say, for each one of the things I've mentioned today, there may be 2 or 3 other conditions which people say, but this is it. But hidden between this is it may be the rare disease. So we need to find them as well.
Okay. Thank you, Prof. I think all the questions have been answered. I've also just in the chat pasted the link to the laboratory's website. So every protocol is on there for all of the tests, amino acids, serum, urine, and so on. So feel free to visit the website. There's also some information on how to do the collection and things like that. So yeah, I don't see any other questions in the Q&A and in the chat as well. So I think we have then come to the end of the session. Yeah, I just wanted to just make an excuse for the rest of our normal colleagues that attend. So we have a conference and majority of them are involved there. So they are otherwise occupied for tonight.
And then,
So
sorry,
sorry, Prof.
just to remember, all of these will be on YouTube. So all these talks and things, if you want to look at them again, they will all be on the YouTube channel.
Yes, and then just one last admin request. So there will, once we close the webinar for tonight, there will be a survey that you can partake in. So please do participate and complete that for us if you have some time. We would really appreciate it. Okay, then thank you very much for everybody that took the time out to attend. And Prof, thanks again for your time tonight. Thank you. We have come then closing off.
Thank you, everybody. Take care.
Thanks, everybody.